Welcome to Ethics and Guardianship. We're going to be talking about rights and the decision-making process. We have Crisstina Morgan with us. I'll do a better intro to her in a moment. Some etiquette around today's. Please keep your mics muted. We are going to utilize chat for questions and comments. This is going to be very interactive, so you can ask questions in time throughout the entire training. We'll have lots of opportunities for people to give input. We also want you to know that you will receive the slides in a follow-up email. You will receive a link to the recording, and you will receive any training materials that Crisstina would like to send out to you. And then we will be sending you a survey if you are interested in receiving CEU credits for this. We have 2 ethics CEUs that are available to people. You have to have live attendance for our entire time here together today. And you have to complete the survey that we send out to you to receive those CEU certificate. And then we have a YouTube channel that has over 40 trainings posted on it. And you can, watch all of our amazing trainings that we've had over the last 4 years. Okay, and then just a little bit about the Older Adult Behavioral Health Initiative. I'm an older adult behavioral health specialist. My county is Josephine County, and there are specialists across the state. I don't know if we have 24 at the moment, but almost every single county has an older adult specialist in it at the moment. We do collaborations and coordination and systems of care. We foster learning, confidence, and connection through workforce development trainings like the one today. And we do community health and wellness promotions out in the community. And then we provide complex care consultations. And we are funded by the Oregon Health Authority. Many of us are embedded in our community mental health program or our area agency on aging. And if you want to find out who your specialist is in your county, you can go to oregonbhi.org, and there's a Find Your Specialist section on that. And so we are a very, very good resource to know about and utilize. Okay, so I want to welcome our speaker. Crisstina Morgan is a graduate of Washington State University. She's worked in mental health for over 25 years, and she has also worked as an APD case manager. So she has a good understanding of like all of the different aspects of working with individuals with specific needs. She is currently one of our deputy public guardians with the Oregon Public Guardians and Conservators. So I'm very happy to have her present today to increase our knowledge and understanding of what guardianship is and what it is not. So I'm going to hand it over to you, Crisstina.
Well, thank you very much. I'm really, really glad to be here. I'm not a big fan of sitting having people talk at me. So I've tried to make these slides and this presentation as interactive as possible. So, as our host Angela was saying, this is going to be a real-time comment, real-time. I want it to be discussive. And so you'll get like a better idea of, well, and as I was telling Angela before we started, there really is no specific fully wrong answer when it comes to guardianship. So that's why this is very scenario based. And we'll just go through all the implications and like everything that we do every single day as guardians, the decisions that we make, the conversations that we have with our leadership, our other deputies, etc. So I think Angela and I had actually discussed prior to, I think we've got enough people that it might take a little bit long to do the one thing you've learned about guardianship. But I wouldn't mind if everyone would just give their name and maybe just a quick, like, where are you at? What's your role? We can go through that and then feel free to share, anything that you don't know that you're confused about, questions that you have with regards to guardianship in the chat. And I think Angela's going to be monitoring that because I will probably not do that very well. Oh, we have APS in Medford. Oh, wow. Okay. We've got some really great experience so far. That's awesome. So yes, please feel free to drop all of that in there. And if you so choose to introduce yourself, verbally if you want. We've got definitely, I mean, we're just starting out. We're less than 10 minutes in. We've got a couple hours, and I do want this to be as interactive as possible. So, anything you wanted to add to that, Angela?
No. But
Mm.
if someone does want to answer the question about guardianship, unmuting yourself, you could do that. It might be quicker than typing it in.
For sure.
Matthew, you want to unmute yourself?
So, what I have found interesting about guardianship, as first of all, I was the guardian for my late father, but guardians have the legal right to place somebody, but really don't have the legal right to uh, force the consumer to do what they don't want to do. So, it's kind of interesting. Guardianship is needed in most cases for secure or, involuntary placement. But then the treatment that follows appears to be handcuffing the guardian. And that contradiction is something that I deal with in my current position, as well as I did with my late father.
We're actually going to get into a lot of things that are really going to go linear to exactly what you were just discussing is um again, kind of why I'm presenting these scenarios is I want to go through, like I say, a day in the life of a guardian where our struggles are and where we're ultimately the things that we're taking into consideration with regards to trying to assist to make best decisions for an individual. Because again, a brief conversation that I was having with Angela before we started is, I always tell people that guardians aren't the end all be all. We're not overlords. We don't do any of that. What we do is we stand aside them. And I made this analogy, however funny or whatever it is or is not. I'm a terrible bowler, but we're the bowling guards. Like we just kind of like stand there and just try to make sure that they're staying in their lane and that they're not becoming a major danger to themselves or others. And we're confidants, we're counselors of sorts. What when I was an APD case manager, someone referred to me or said to me, guardianship is case management on steroids. I don't disagree with it. And it's like a family member, a case manager, many of the roles that we all are currently in, or ones that I was in prior, but with like a lot more technical oversight. But there's so many different things that we have to consider when we're making these decisions to try to assist an individual to make best decisions for themselves. So.
Any other comments on guardianship, things that you are looking forward to learn?
And please throw questions in anytime. Like I say, Angela's going to be monitoring it. So if a question comes up and I don't see it, she'll let me know and we can address it at the time. But I really do want as much input as possible as we're going through these scenarios because it's going to help like I'm very familiar with these scenarios. These are actual real life cases that we have dealt with and are currently a lot of them are active cases in OPGC with one of the other deputies. And I've got, my own examples that, at some point, if they need to be pulled in, we can. But I think that this is going to be a very good discussion. So please, again, as interactive and as many questions, I would love it if we don't get through all the scenarios. I'm better with that than you not asking the questions that you want. So.
Perfect. Are you going to be explaining the difference between emergency guardianship and permanent in your intro slides?
No, but I can give a quick
Okay,
blurb.
will
So
you
basically, yeah,
will you include that when we get to that
sure.
section? Cool. Okay, well, we can start with our agenda for today.
Okay. So we're going to, as this slide is saying, there's the NGA standards, ethics, and decision-making framework. I've put a couple slides in there with regards to that, and I am happy to send this slideshow out because it does give you a very good format for what we look for, what NGA standards are, what we are certified as certified guardians and conservators. This is our guidelines. This is how we work. This is the ethics and the standards that we go by. And like I say, we're going to go through many different scenarios, and you're going to kind of see these play out in real world, real life. So, if you want to move on to the next slide, sorry, I'm saying entirely too often. I apologize. So here are the 25 standards, the form of code of conduct and instructional guide for guardians. And this is kind of our I don't want it to sound sacrilege, but it's to a certain extent, it is a roadmap or a Bible, for lack of a better way of putting it. This is really what we look at. So does anyone want to maybe read a couple sections or something? Interactive, come on. Okay, so I'm just gonna go, okay, hard to read with the screen. Oh, okay. Let's see. Angela, can you make your screen maybe full screen? Is it not a full screen?
It should be a full screen, but some people's screens might just be smaller.
Okay.
Yeah.
So kind of the highlights are you advocate for the individual, and there's a lot it quotes all the different codes of conduct and the 25 different standards, and it actually numbers them of when we promote personal relationships between client and his or her family. That's number 4 in standards and guidelines. Make thorough decisions, inform and support the court. That is a big part of our job, is that we are interacting through DOJ with the courts all the time. This is an absolutely legal process. And just as a little side note is that an individual that comes under guardianship is deemed legally incapacitated, not psychologically incapacitated, not mentally incapacitated, not physically. There are crossovers between all of those, but legally incapacitated is a legal term, and there are definitely standards that an individual must meet for us to be able to petition the court for them to be considered legally incapacitated and come under guardianship. And potentially, uphold professional and business ethics. This is probably a good time, just because I was just bringing up the court system. Temporary, a lot of counties are not very comfortable granting emergency or temporary guardianship. Usually the courts will grant it. The counties that are comfortable with it will grant it under very, very specific, imminent, immediate. You've always got to have that imminent, immediate, very, very much danger. They're unhoused. They are, very much at physical, health, mental health, physical safety issues. So that threshold has to be met for any court to even remotely feel comfortable in the counties that will grant temporary and emergency guardianship. What ultimately ends up being the case for the bulk of basically all the cases, we may start out with emergency guardianship and OPGC, but it's called indefinite guardianship. It doesn't mean it's forever, but until the court, either the individual is able to prove to the court that they are no longer an imminent danger to themselves and they no longer need guardianship, they can petition as many times as they want at any point. They can fight the guardianship orders. They have that right. It's all very legalese, etc. Or OPGC petitions the court and says, we really actually think that this individual can take care of themselves now. Then that indefinite will stay in place. So it basically takes a court order for them to come into guardianship to be deemed legally incapacitated. The emergency and temporary only lasts for 30 days. You can extend it, but it's not the indefinite. So like I say, the bulk of the cases that we're working with are indefinites whether they started out indefinite or whether they started out emergency. So I don't know if I explained that well. Please let me know if I did not. If you've got any more questions with regards to that. But basically, again, this is a really, really great slide because it does give all the guidelines that we follow. So, Angela, if you want to move on to the next slide. And this kind of goes back to NGA ethical principles because this is kind of what we're talking about with regards to this. This gives a very good breakdown. These are all the line items that you think of, and line items sounds very sterile, but these are all the things that we are thinking of every day, every time we're making a decision with regards to an individual. And again, they do align with the standards and the guidelines that we all have to adhere to, and that's where we're certified on. And if we don't adhere to these, we could lose our certification. And I don't see that. I've seen it before in individuals, but like OPGC, we're always checks and balancing with each other. So these are standards that we adhere to. And then the next. So I'm really trying to get y'all to be interactive. Does anyone want to read any of these? Like, again, this is like a day-to-day process that we go through. 1, 2, 3, 4, 5. These are different things that we're always thinking about. Anyone? I'm going to do like a Bueller thing. I'm dating myself when I say that. And I see one of my, it looks like one of my cohorts is on here. Julie, I might call on you. We have another deputy guardian, unless it's a different Julie Rivet. We've got one of our other deputy guardians on this call. So
you also have Vicky.
oh, okay.
I am attending, but I'm not going to be on video if you need me.
That's totally fine. Do you want to read these, or can you read them? People are saying it's kind of difficult to see the slides.
Guardian decision-making process, the considerations that lead to well-supported person-centered decisions, understanding the issue thoroughly, like what is happening and how it's affecting your client. We have to identify the facts of the situation, including urgency to act and the consequences of delaying the action. The possible solutions, we need to diligently assess the options, get multiple options or recommendations when appropriate, compare the choices, including their possible short versus long-term impact on the health and daily life. And we have to assess the risk and benefits of all options. Third is the client input, which after we assess the problem and the solutions, we always verify with our client because that's who we advocate for. And that's one of the most important things about Oregon Public Guardian is we value the client input, and it's really important to Oregon Public Guardian. We ask the clients what they want, offering technical and other supports necessary for them to respond. If a client is unable to participate in the discussion, then we ask interested parties, review the past choices, and consider cultural norms. Even if the state standards focus on best interest decision-making, it's important to involve clients as much as we can. So we reach out to their families, we reach out to previous caregivers. For example, I have a client that he's unable to communicate. I access his caregivers for the last 17 years. I reach out to his family members and ask for their input before making the decision for that client. The standards of practice include our guiding principles, which are the 25 standards, and that was basically some of the stuff that Crisstina already reviewed, and then the deal breakers. Having a reality check. Will the client comply or follow through? Are necessary resources or supports insufficient in your area? And are there factors that might influence or override the decision? And that's huge. I mean, like, we can't force our clients to do anything. They might not follow through. And are there necessary resources? Right now, we're in a world like with mental health where there aren't placement resources or supports that are sufficient. Other factors that might include or override decision, I'll hand it back to you, Ms. Crisstina.
Like I say, there's so many different things that we're taking into consideration, and every case is different. You have no idea, you're going to deal with A, B, C, and T, and you might have been familiar with A, B, C, and T, and then all of a sudden you're dealing with another case that has A, B, C, and Z. And so all of everything colludes to ultimately help us make the most spherical and best decision that aligns with the wants, needs, and desires of the individual client that we're working with, the individual consumer, Oregonian. We refer to them in many different ways. So whatever speaks to you. And looks like Matthew, do you have a question?
Yeah, so lived experience, having been my late father's guardian, these appear to be what the court yearly report is asking to be captured. For those that don't realize, the yearly report that is due to the court.
Yes.
Is that too simplistic, or is that, I mean,
No, it's not. I mean, basically, the annual Guardian report does capture their physical condition. And currently, so this is their physical condition, and this is how the needs of their physical conditions are being met. Here's their mental and, cognitive. This is how, wherever they're residing, whatever we're doing with regards, like we do have to make a justification as to how we know what's going on with them and how we're actually managing these different aspects of their life. Like I say, physical, mental, financial, all different aspects. And yes, it's the gosh, the court reports are probably about 8 pages long, and they're a petition like anything else. That's essentially, again, we work with DOJ, we write the report, DOJ kind of fine tunes it, and then they actually submit the annual Guardian report, and it's every year. So yes, it does align with a lot of what we are reporting in the AGR, or annual Guardian report. So very good question. Thank you, Matthew. Okay. And this literally just aligns with everything that we said that we've been leading up to now, we must have a clear understanding of the options, expected outcomes, risks, and benefits of alternatives when making decisions. So again, very constantly checking in, constantly checking in with the client, checking in with the facility, checking in with ourselves, checking in with our, other guardians, checking in with our leadership, making sure that we're always trying to take as spherical and as vastly understanding as we can that is going to give this individual the most amount of independence and respect as we are working with them. So huge. And then I think the next one might be the first scenario. Let's practice. Woohoo! Okay, so let's go. Oh, okay. So just a quick side note, we do deal with Pulse, DNI, DNR. There is a lot of misinformation across all aspects of the guardianship role, the individual being placed in any kind of RCF, or residential care facility, assisted living facility, mental health, secured residential treatment facility, skilled nursing, like all the different things, hospitals, etc. When an individual comes under guardianship, it is always good to have some kind of post in place. Our younger individuals do tend to be what's called full code, which a lot of, I may be explaining things pedantically, and that is not my intent. I'm not trying to downplay anything. I just want to give the information. So whatever is not understood, or if I do not explain it correctly, please again throw questions in. But POLST are it's the lifeline. It's if an individual does present in some way, shape, or form unable to make their own, with an inability to make their own medical decisions. If they present to the ED and they're unconscious, this is the form that they can go to. Doctors are supposed to be filling out the POLST with all clients. And like I say, there's a do not resuscitate, that's DNR, do not intubate, DNI. And a lot of the individuals that we're dealing with are DNR, DNI. Some are not, some are full code. Again, typically when they're a little bit younger, they're wanting all measures to be intubation, resuscitation, everything to be managed if they were to present in the ED unconscious or in a life-threatening situation. But again, a lot of our individuals that are older, there's a very big want with them that their life is not extended in a way that would be undesirable to them. So we have polls that are all across the board. We do attempt to register them. There is a national pulse registry. This is, again, it can be somewhat of a cumbersome process as we're dealing with so many different entities with regards to the pulse. But, and again, a lot of misnomers. You got a lot of, I've had individuals that are on hospice care. Yes, it isn't. So sorry. Matthew was saying registry is not good for 10 years. It's only good for 10 years. I typically am trying to update mine more often than that because things do change, especially in older neurocognitive decline individuals, usually will change in less than 10 years. So I'm revisiting that with the people that are around them all the time because as the guardian, I'm not around them all the time. Their facility staff typically is. So I'm having pretty consistent conversations. You will get very differing views with regards to, like I say, I've had a number of individuals that have been put on hospice care that are residing in some kind of facility, and you'll have the hospice nurse call in some damage. Very specifically, I had an individual that fell in the main bathroom and got a pretty intense contusion on her head, and they were worried about a brain bleed. And she wasn't an imminent hospice, like we're actively passing at this point. So I actually had the hospice nurse reach out to me directly and said, "Do you want me to send her out to the ED?" And I said, and I had to think about it for a minute. And I staffed with leadership and I said, yeah, ultimately I got so much pushback. The clinician that had put her on hospice, which is no longer involved at that point. They actually go with the hospice agency and all clinical decisions are made with that hospice agency. So that primary care physician is no longer a part of their healthcare team. I got really intense pushback from her and also really intense pushback from the facility. As the guardian, I wanted to make sure that when she fell with this pretty intense contusion, that she didn't have a brain bleed that was actually going to cause her to expire much earlier than just her basic hospice would have possibly allowed her to do. Because basically hospice care is you don't get sent out, you don't get checked, everything is just managed in the facility or in home. And I had to make that decision because I wasn't comfortable with her possibly having a brain bleed. So that can be stressful. So it really can, because like I say, you will get a lot of pushback from a lot of people, but ultimately as the guardian, you're trying to make the best decision that you think that that individual would make in the stead of, you're here, like they're kind of absent or unable to make a fully informed decision. So you are using everything that you know to try to make the best decision for them. She had a very involved daughter, and I knew that her daughter would be very, very upset if I hadn't sent her out to the hospital. So there a lot of things went into that decision. So anyway, so that's the Pulse DNI, DNR, comfort measures, conversation, and it's not black and white at all. It's very, very gray. So, so I guess now I think we move on to the first scenario, Angela.
Yeah.
Okay. Does anybody want to read this? You guys don't need to hear my voice the entire time. I don't even like my voice that much. Come on.
I will do the first one just so that
So it's not just me talking the whole time. Okay, go ahead.
Get people warmed up. 69-year-old man under guardianship after hospitalization for acute encephalopathy, severe hypothyroidism with impending coma, cognitive impairment, and other medical conditions. So possible developmental intellectual challenge, 8th grade education, placed in memory care, improves significantly with supports, desperately hates memory care, believes he can go live on a friend's property, hasn't seen friends in years, isn't sure of friend's name or location, wants DOPG to locate friends so he can move. What do you do?
Okay, so this is where I want everybody's input. I just out of everything that you see, all the different facets of this is a case that I worked with another deputy on pretty early on. as a deputy, and I'm curious as to what comes to mind, or what are the things, the aspects that you think about with regards to this case. What are things that you would take into consideration?
So Kathy in the chat says, see if can place in a smaller setting, like an adult foster home.
That's absolutely a good idea. Um, because a lot of individuals really don't deal well with the memory care, and more often than not, you're sharing a room in memory care. And I found that my male clients deal less well with sharing rooms in memory care than my females do. And that's not meant to be a generalization. It just tends to be a trend that I see. Um, Anyone else?
That seems like a extreme change to immediately go to memory care. If there's not, I mean, memory care in most cases is for flight risk, possibly people with sundowners. So I agree, like AFH, but maybe like even a in-home support person. But there, that is a broad stroke
It is.
placement.
So in this specific case, this individual was unhoused and long-term in the hospital, which is oftentimes how we get a lot of our cases. So they don't have any safe placement. They have no real discharge planning. So the hospital's going, they've been here for 6 months. We got to find some place for them. So sometimes, especially when individuals do present with like hypothyroidism and, potentially developmentally, disabilities, they would discharge to homelessness. So putting them in a temporary placement that may not be the best placement for them, um, ultimately long term, is at least getting them safe and able to discharge from the hospital. So this individual was put into the memory care, did not like it, and ultimately, the deputy in question was able to find the friend. He had been this our client was actually a circus worker his entire life. So the individual friend in question was a former connection from the circus. We actually have had him for almost 2 years now, set up in a trailer on this individual's property. It's not perfect. So there's things that, the deputy that's working with this individual has to continue to address. And that's what you always do. I mean, sometimes you get someone and we fully stabilize them and everything is great, and that's great. And then you're just continuing to check in on them. This specific situation does not tend to be that, but we have an amazing deputy that's working with this person. So it's always stuff like this. It's troubleshooting, looking at all the resources we possibly can. I know the deputy in question was attempting to get his dog to be able to live there for a while. That didn't end up being able to happen, but he is relatively stable, but he does not, he's been drinking a lot of alcohol, which, is causing some issues with blood sugar. So again, these are things that you are consistently having to address, but he was doing with supports, he was doing well, but the memory care was ultimately going to be a very negative thing for him. So that was why the deputy looked into an alternative option and had him move out. And in the long run, in like the big picture, he's actually doing better than had he stayed at the memory care. But that is, again, like, there is nothing black and white about that. It's very situational, and it's all the things that you have to consider, and staff, because there's always going to maybe be a deputy or one of our leadership team that's going to think of something or pick up on something that you didn't necessarily think of. But he is, like I say, relatively well. He's doing relatively well. So.
And it seems like this is a good reminder about least restrictive means, that memory care is kind of the, a higher level of, to try to do other things first. In the chat, we had Casey Roberts said that they would likely spend time exploring their experiences with that friend, interviewing, working to understand what values they
Very
have,
much. Hmm.
discover ways we might meet some of those needs while also ensuring that they're cared for appropriately.
Hmm.
So yeah, that's amazing that the deputy was able to locate the friend despite the lack of information.
But I mean,
Uh,
everything that's mentioned, everything that everyone mentioned in the chat is all what goes into those decisions. There is no wrong comment. There is no wrong. These are all things that you want to take into consideration. And least restrictive and the thing that aligns the best with the individual's wants, needs, and desires, for lack of a better way of putting it, that they can live as independently but also safely at the same time. This ultimately ended up being that, but I know that the deputy in question continues to assess that situation, as we all do. If it becomes more unsafe or untenable, like not able to, sustain the safety of this individual, then we reassess and then you move from there. So, but all great suggestions and all great things that you would think about. So thank you.
should we move on to the next scenario? Okay.
Oh,
Or we continued. Sorry.
well, no, it's
This is
okay.
the,
Let's go
yeah.
ahead and move on from this because that gets even that much more involved. Let's move on to
Okay.
scenario 2. Anybody want to read this? I'm getting no volunteers today, y'all.
We are so
I can
not
do it.
used to
Okay,
interacting.
Matthew.
So,
Matthew volunteered.
financial scenario: 55-year-old female under guardianship due to schizophrenia, schizoaffective disorder, history of traumatic brain injury, recent significant weight gain, and need for oxygen. Unable to use walker due to shoulder injury. Doesn't like manual wheelchair because it's hard to scoot with her feet and carry the portable oxygen. Wants to buy another residence used electric scooter for 500. Looks forward to driving the scooter a few miles up the road to buy cigarettes. Assisted living facility states the scooter won't hold a charge and control mechanism doesn't work. What do you need to know? What standards, ethical principles to be considered?
Oh, you are muted, Christina.
So, Matthew, when you read this, what are the things that jump out to you immediately that are probably like, wow, I really need to think about this, this, and this, at least initially? Yeah, Kathy, that's a very good. I'm sorry, my cat apparently wanted to join. I apologize. That was like, wow. Frustration
So,
be with responsibility of the hospital discharge. Okay, sorry. Go ahead, Matthew.
yeah,
I
I
did.
kind of wonder so in foster care, at least for mental health, Comagin has the IBL, so the individual base limitation.
Mhm.
Interesting enough, a guardian cannot be the only signature. It also has to be the consumer, even if they're under guardianship. But we had a consumer where the guardians had to go to court to get a court order to leave foster care to go to a higher level of care. I'm wondering if this would be a situation where it would require a court order to restrict their ability to take the scooter to the store to get cigarettes due to these concerns.
Technically, yes. Did I mean myself? No, I did not. So any kind of restraint, and IBL is, what you're talking about. I totally forget what IBL stands for now all of a sudden.
Individual based limitation.
Thank you. Yes, typically, like any kind of IBL, it can be agreed upon by it really is between the state and the client if they're on Medicaid. So the guardian doesn't necessarily have to step in an IBL situation. However, most facilities want the guardian to, on behalf of said individual, agree to whatever IBL that they are actually presenting to the state to be approved. And I mean, so in this situation, I would have zero problem having the conversation with the facility of, I don't think this is realistic. And I wouldn't necessarily feel the need to put an IBL on the individual or, put an IBL in place. I would just say I don't think that it's really prudent that you buy this scooter because I don't really know that you're going to be able to safely manage this. And that becomes, so, again, in decision making and guardianship, that becomes that imminent danger to themselves and or others. Because I don't know if you've seen individuals driving around motorized scooters and or motorized wheelchairs that do not know that are a danger when they're out there and are running into things, running into walls, running in and knocking over people. If it is realistic, you can say, yeah, I don't really think that's a good idea. Again, would you put that in your annual guardian report? You would. Stronger, larger, more overreaching restrictions would need to go to the court to be approved. OPG would have to put a petition, hey, we're actually wanting to put this this limitation on this individual, and the court would have to agree. But those are typically more designed for individual limitations when we're putting a restraining order and or a no contact order on an individual. Those actually do need to go through the court system and be approved by the court. So
there are a lot of really good things being put in the chat.
Okay.
So we have Kathy asking the question, can this individual safely operate the wheelchair outside in the community and return to the facility is the question. Engage either PT or OT to evaluate if they can safely drive a power chair and possibly have insurance cover it. Having the scooter mechanically evaluated, explore various purchase options. Are they safe to go out in this capacity? Can they negotiate a crisis? Check with PCP for an order for a new electric chair. Does she have the skill to use a chair in the community? I think we're having the theme of evaluating whether or not it is safe is the first thing. Yeah.
You're doing your due diligence, and that is a lot of what we end up doing. Even if we know this isn't the best idea for, said individual, I always do my due diligence so I can have that conversation and feel like I have fleshed this out as much as I possibly can, and I am making a very, very informed decision. And then, like I say, staff the, heck out of it with leadership and other deputies and see if you've got any other suggestions. So yes, as much as we always possibly can, we want that independence. And obviously, as you well know, a lot of our individuals that we're dealing with, that we're working with, have ambulatory challenges. So if that can give them that level of independence that they have not been able to have, I'll work with it as much as I possibly can until I know that it absolutely would be an imminent danger to themselves or others. They'd be running into things, people, etc. So yes, these are all awesome suggestions, and everybody is thinking exactly along the lines of what we do in our decision making every day.
And Matthew did make a good statement that most assisted living will not have
They won't have,
PT or OT accessible. I know that that's down here in Southern Oregon. We want OT, but whether or not they're available, PT is more available than OT.
PT and OT, it depends on kind of where you're at. A lot of like Riverside Home Health, Bristol, there's a multitude of agencies that will actually go into facilities, not all of them. If the individual has to navigate to an offsite physical therapist, that oftentimes they cannot make that work. But more often than not, most of the home health agencies are actually willing to go into the facility and actually do PT and or OT on site. That being said, you get maybe a handful of sessions, and if they're not seeing this drastic change, they can't justify it to insurance because, insurance is wonderful. I say that very sarcastically. Not that it's not, but, they can get maybe like a handful of sessions, which for a lot of our individuals is just simply not enough. So yeah, there are a lot of challenges that come along with that. But all stars align. And as a guardian, like I'm advocating for PT and OT for my clients all the time, and I will continue to advocate for it. So many individuals that do reside in these places don't have anyone to advocate for them. And that's sad to me, but it's just the nature of things. So Matthew, it looks like you've got a
Yeah.
question.
So, being that they're in an assisted living and they have a SPMI, so severe persistent mental illness, they could likely have outpatient case management through a mental health provider. We here in Jackson County, we are prohibited as our part of our case management from taking consumers to purchase alcohol or tobacco, but we can other community engagement and shopping. Where I'm going with that is, would you as the guardian step in to help with the purchase of the tobacco, so then all of the other case management shopping could then meet their need and their desire to get out safely, and so they get the full wraparound of case management while also getting their nicotine fix, if that's their choice?
So I take clients shopping all the time. I do purchase clients tobacco. I don't purchase clients alcohol because it's not that I'm opposed to them figuring out a way to get it through a natural support or whatever, but state vehicles, we are not allowed to have any kind of alcoholic beverage. And there's just, to me, I'm like, it's not that I'm opposed to some of my clients having alcohol, because I know that they would essentially be safe. Like, I do have clients that drink alcohol and they're essentially safe. I'm just not able to buy it. But yes, I actually purchase smokeless tobacco for a number of, and have purchased smoked, like cigarettes, for a lot of my clients. I don't have any issue with that, just as long as they're safe and the facility allows it. You do kind of run into a challenge. Most memory cares do not allow smoking because it's a safety factor. And the smokeless tobacco is a little bit different, but oftentimes the rule is the same no matter what. They can't have any kind of tobacco. So I'm always advocating for that. Like, I do believe this person is going to be safe. Is there any way that we can make some kind of agreement so they're actually getting the things that they enjoy in life? I mean, I had a client on hospice, and it was god awful listening to him. He had a terrible COPD, and his lung function was, ultimately, that is actually what he ended up passing from, but that was his choice, and that was not my right to take that choice away from him. So I would buy him cigarettes, and I'd go, okay, well, maybe smoke a little less. That still was ultimately ended up being his choice, but it didn't mean that I didn't share my opinion, because I did care. I do care. And but yeah, again, not also something that we tend to hinder for most of our clients. So
Well, before we move on to the next one, Tammy had a really good note, experience, and a reminder that she had a client that was using an electric chair, and the facility reported that he was running into people in walls. Had the chair been checked by the medical supply, they had found out that the joystick was broken, and he had reported it many times that it was not working correctly. They were able to get it repaired, and he was able to use it with no concerns. So I think that
great
shows our
example.
biases, and letting frustrations possibly like get in the way of actually investigating.
Well, and oftentimes also, again, as an advocate and as a guardian, you do run interference at a lot of the facilities, because they just are like, I just want everything, not just one person, but the facility just wants everything to be simple and easy, and they don't really want to look into, nor do oftentimes our so many of our facilities are so understaffed. So that's a lot of, doing my due diligence also as a guardian, as I go in and I try to troubleshoot. Because if I can figure that stuff out, just like what Tammy was saying, I'll take on that role. So they have that more independence, because, you figured that out, and all of a sudden he's got all this independence. So that's amazing. So yes, advocacy, advocacy, advocacy is a big part of guardianship.
Okay.
Anybody? Do you want me to read this one? Okay. Medical decision scenario, 47-year-old female with cognitive impairment due to polysubstance use, post-traumatic stress, and many serious medical conditions, recently discharged after a 15-month hospitalization. Doesn't want DOPG at medical appointments, is not an accurate reporter, is confused when given medical information and instructions. From the OPG policy manual, it is the policy of the OPG program to be involved in some manner in all medical appointments and treatments involving protected persons and to maintain some level of documentation regarding the visit, the outcome of the visit, and the plans for future visits and treatment. What ethical principles need to be considered, and what do you do?
I mean, is this a time when you let them know that you are required to be present at their medical appointments to
This
a degree?
Yes, and this specific deputy that worked with this individual, it has been a really intense struggle. This individual is chronically unhoused. There is a lot of there is an SPMI, there's a PTSD piece, there is again polysubstance, and truthfully, she tried to navigate it as much as she possibly could, the deputy in question. And ultimately, it ended up becoming a safety issue for her. So she continued to try to set up medical transport to get this individual, tried to meet her there. And oftentimes, these are the frustrating situations that we can run into, is that proverbial you can lead a horse to water, but you can't make them drink kind of a thing. It's like, I'm going to try to do everything that I possibly can to get you the services that you need. But if they dig their heels in and they are absolutely non-compliant, there's a part of that that ultimately we can try so much. And then we kind of got to go, okay, I'll just continue to do as much as I can, as much as you will allow me to. And you just continue to run interference, for lack of a better way of putting it, also, and do the best you can. But I do believe that that the deputy in question actually does still struggle with compliance from this individual. And she really isn't safe. The deputy in question would go pick up this individual from one of the unhoused encampments, and the client would be dangerous in the car. And so then that actually becomes an entire different safety issue. But it's not uncommon that we navigate situations like these where a person is unsafe and we do the best we can. So
And Casey Roberts wrote, identify a person they feel safe attending the appointment with and maybe access their MyChart or equivalent before or after the fact, so you can have available to medical staff to answer questions accurately, while also acknowledging the individual feels more comfortable without you present. So do you, as a guardian, does that give you access to someone's medical records, like their MyChart, with that
Yes.
guardian status? Okay.
But it's always a struggle. The particular deputy that we're talking about here says we probably spend about 90% of our time explaining to others what we actually do and what our access is. It's financial institutions, it's medical institutions, so we do spend an inordinate amount of time saying, well, I mean, like, here's the legal documentation. I keep the judgment and the letter of guardianship on every single one of my clients in a backpack that I have files for. It's my mobile office is what I call it. So I always have them on me, so I'm able to provide those. If I'm there physically, I do send them over, fax them over, etc. Hospitals tend to work pretty well with us. Financial banking institutions, not so much. But and then and private medical offices can be somewhat of a challenge there. It's about a 50-50 split. But yes, you do have to do a lot of explaining, and then you are trying to coordinate with them. And ultimately, it's in their best interest, because knowing that you actually have someone that could speak on behalf of this person takes a little bit of onus and liability off of the institution, the respective institution. So, like I say, a lot of hospitals are like, oh, yeah, please. And we sign the paperwork and we do all those things. But yeah, it's a pretty consistent struggle, especially if you've never dealt with said hospital or institution that you're working with. They know nothing about you. And we did have a recent, and this is rather unfortunate. We have a lot of our clients, our consumers or Oregonians that will present 100% cogent. They present very, very well. And so, they're going into a doctor's office or the ED or whatever, and the clinician is believing hook, line, and sinker. And I don't say that to be mean, but they are believing everything that this client is saying. And so it's a huge challenge to have the struggle. And we had a recent, in the last 6 months, a clinician, a PCP, a primary care clinician, was refusing access for the deputy guardian in any of the doctor's visits because he thought that the client was just completely fine and the deputy was overreaching. And it's like, this is actually a legal judgment. You do need to let me have access to this and all of that. And so it became quite a, I don't know, challenge. I mean, I don't really know how that ultimately ended up working out. I just know that it was an issue for months, and I don't know where that case is at right now with regards to that primary. He just believed that the individual didn't require guardianship and the individual didn't want guardianship. And he was very honest about that with his primary. And his primary started blocking the guardian from even being able to have any access. And that's really challenging in situations like that because like we have that we received the referral. We've got all the background information that oftentimes these facilities or these clinicians, professionals, whatever, didn't necessarily have that information. So those can be challenging, but they do happen. So.
Before we move on to the next one, I actually want to give people a 5-minute bio break because we're right at 10 o'clock. So we come back at 10:05 and we will start back up. Does that work for you, Crisstina?
That sounds great. Thank you so
Okay.
much. Great
You're
suggestion.
welcome. Yeah. So 10:05, we will be back for the next one. Okay. Let's see. So we will get going again.
Do we want to start with number 4? Are we going to wait for a few minutes for any possible stragglers, or do we just want to start?
I think we can start. Do we have a volunteer from Chris?
I'll volunteer, but can you hear me?
Yeah,
I
yeah.
can. Yeah.
Okay.
Thank you.
I have fans going everywhere. Okay. Autonomy scenario food part 1. A 58-year-old female with Vernix dementia and insulin-dependent diabetes at significant risk of medical complications from diabetes due to her diet, doesn't like to eat real food, snacks all day on candy bars, cupcakes, Twinkies, donuts, etc. and spends hundreds of dollars each month on these snacks. And per her PCP, primary care physician, blood sugars are currently in acceptable range with medication and insulin.
Sorry, I did not want my water to whistle too loudly, so I apologize. Okay, so what do we need to know? What standards, ethics, principles need to be considered? What are y'all's thoughts?
Well, someone asked, how is she getting the snacks?
So interestingly enough, I will give you the prime example of oftentimes they are shopping with us and getting the snacks that way. And I say this because this does tend to be a pretty common issue where the facility will be like, just don't allow them to buy that. And we have to remind them, that's not my job as the guardian. If it becomes an imminent, like, oh my gosh, the blood sugars are out of control. I mean, basically this is, the diabetes is being managed by her meds. And as an independent, and, we want these individuals to have independence and respect and keep that autonomy as much as they can. So like I say, would I be shopping with one of my diabetic clients and be like, do you really think you need that? And they'd be like, yeah. And I'd be like, okay, maybe let's buy a few less boxes or whatever. And that's really the oversight. That's what I mean. I would be diabetic myself.
So Casey, Casey wrote that the last point is the most important. Her disease is technically controlled. So even though her diet isn't healthy, she has the right to self-determination.
And truthfully, what we say is it does not really matter. Even individuals under guardianship are allowed to make poor decisions. I have clients that utilize illicit substances. It's very, very not healthy for them, but our individuals are allowed to make poor decisions until it breaks that imminent danger threshold.
So Luhati, you have your hand raised.
Yeah, I was gonna type, but I was like, no, I think I just rather go off mute. So what is her health literacy level regarding her conditions? And what is it about the taste of the food that she's not liking? Because sometimes medications do have you can have that metallic taste. And what is she craving as far as the sugar? Is there a need? Is there a medical need that she feels that she needs to satisfy? Or the fact that she's insulin dependent, that restriction in itself can have like a mental, restriction. It's like the MPO. I use this as an example all the time. The minute you have the MPO 1201, you're standing in front of the fridge because you're restricted. That mental restriction may have an effect on how she's reacting. And also fulfilling that, not only that taste need, is there something else that she's seeking that she may be able to achieve from something else? You know, that high from the sugar, or the fact that, as I mentioned, the restriction, that defiance perhaps. And if it's being managed, like, you know, is there something else that they could provide as far as that distraction piece? Anything else? Or even healthy choices. What does healthy choice look like for her? Because this might be her pattern that, hey, these things fulfill me, I get full, I'm satisfied, but then there's 0 calories. And then it goes back to that health literacy about diabetes and nutrition and healthy eating. And then her condition, that dementia piece, what is her level of understanding and retaining that information? And she might also be like B12 deficient. Who knows?
So every single thing you just brought up is all amazing things that you look at because you're looking at everything that could actually be causing this. She's not in any kind of, immediate danger. Her blood sugars are being managed. But yeah, you're right. Like, is she taking medications that are making regular food palpable to her? Is there the defiance piece? I'm sorry, but especially when you get neurocognitive decline, a lot of times you will revert a little bit more back to a younger mentality of things, and you can act a little bit more defiant, for lack of a better way. So you're looking into it and addressing every single thing that needs to be addressed. So great. That was a great uh comment. Thank you. Anybody else?
And Matthew.
Matthew. Yeah,
So I
sorry.
started out as a dietary chef before coming into my current position. And the mantra that we held is that the one thing that the residents had independence over is what they will and will not eat. And that was the dietary's program's belief, is that is the biggest form of their independence, is what they will and will not eat.
And as it's the thing that I like to do the least. I don't want to hinder someone's ability to eat what they want and what they enjoy. I'm a foodie myself. Really, whatever I want when I want to eat it. Within reason, I try to eat pretty healthy, but yeah, that's kind of one of the hills I'll die on, for lack of a better way of putting it, is I tell my facilities, it's like that this is not my place to tell them what they can and cannot eat. You start to talk to me, or the primary starts to talk to me about, we've got some pretty drastic blood sugar issues we really need to address. That's where I'm going to start getting into it. But until then, I feel suggestions and gentle urgings are enough. So yeah, like I say, y'all are bringing up wonderful points. This is exactly the way that we think about it.
This scenario actually is making me think of a client that I've had that lived in an adult foster home and had such horrible teeth due to past drug use and diabetes and just lots of different things. And it's just a constant struggle with the owner of the foster home, because she does have the ability and she doesn't go to the grocers herself because she has mobility things going on. And so when they ask, I've been there before where they ask, like, we're going to the store, is there anything you need? And then she lists off all of the, not great things. And you can just see the nurse or whoever is going to the store is just like, it's just such, yeah. But one of the things that I have been able to talk to her about is like her teeth. So when you're thinking about like quality of life, like those teeth and the pain that she feels is sometimes the way that we can have a conversation about the sugar and the things that she's eating, and Luhati made a comment about the only thing that they have control over, possibly, and that's with her. Like she is completely dependent due to her vision impairment and her mobility. That really is the only thing that she has control over, is eating whatever she wants. Yeah.
Well, like I say, as I mentioned earlier, my gentleman that was smoked a lot and was in COPD and was in lung failure and all of that, but he was on hospice. And it's like, at this point, do what you want. I mean, really, that is not my place to take away what is his only kind of, not even social outlet. It was just really about the only thing he enjoyed. And I brought him sugary stuff. He loved Pepsi, but he loved my visits, and it was a joy to him. And I had zero guilt, and I felt zero bad about it. And truthfully, the facility was really wonderful about it. They're like, oh, he loves it when you show up. You bring all the fun, treats and snacks. And they tried to put a little bit of a kibosh on it initially. And then I think they were like, yeah, he's on hospice. And I mean, he didn't last for very long. I think 6, 8 months, maybe. So he got to enjoy the last time. And that's his right to be able to do, So it can feel weird sometimes though, because you're like, oh, I know I'm giving them unhealthy stuff, but it's like not my decision to make. My decision is to keep them having the best life that they possibly can and give them as many of the independent decisions that they would make on their own. So, and here we go with, in the absence of actual or risk of serious imminent harm, our people should be afforded the very human opportunity of risk of making a poor decision a failure. The imminent part is important: standards, least restrictive, maximize independence, acknowledging personal freedoms, ensuring quality of life. Ethics, dignity, involving the person to the greatest extent possible, least restrictions, advocating for the person's goals, needs, and preferences, and maximizing independence. And then always opportunities for education. And this is the way that I do my role, and pretty much all the deputies. I mean, we work in one form or fashion in this because it's very, very important. Dignity and self-respect and independence we want to maintain those as much as we possibly can in our individuals. But a lot of our facilities and a lot of other individuals that are floating around the case and or the individual don't necessarily understand or agree with the decisions that we make. But you kind of have to be strong as a guardian, and you take that stance and say, not my role, not my right. I'm their advocate. I want to make them as nice and comfortable as they possibly can. So.
Oh, did I go too far?
No,
Yes.
no, that's okay, because here's
there's the number 4. Yeah.
Oh, okay. Then facility reports that our person's blood sugars are way out of control and rising. Multiple occasions of being sent to the ED, ER via ambulance for this. Facility RN will not be able to continue to delegate insulin injections for non-licensed staff if her blood sugars continue to be high and unstable. Placement at the facility is in jeopardy. Here's where it does come into play. You've got an imminent health risk to the individual, and you also have an imminent safety placement risk. If they could risk getting sent out to a place that they probably would not want to be, either back to the hospital and or from the hospital, potentially having to go into a skilled nursing, which is essentially a hospital. So these are where you have to kind of start shifting and having those conversations and getting a little bit more restrictive and talking with them about this, though. Like, I'm very transparent with all the people that I work with. So they at least know. Doesn't mean that they necessarily like it, but I'll be like, we really can't do this because diabetic coma is a thing. I don't want you to go into. You're becoming an imminent danger to yourself. You're becoming an imminent risk in a multitude of aspects, like I say, health and also safety with housing. So these are parts where we do have to step in. So any questions about that?
Okay, I do have a question on the RN. So I've been delegated in an assisted living by an RN. The RN can choose who he or she is going to delegate their license to, but would this not be a case of the ombudsman needing to step in to determine if the RN is unjustly not delegating their license?
So it is few RNs are willing to delegate their license to other staff members because it's their license. It's a huge liability piece for them, and most RNs are actually not willing to. There's certain staff members that they may very well trust, but it's very, very common for insulin dependent individuals to not even be able to be placed because facilities kind of tend to shy away from that. There are your special needs contracts that will allow insulin dependent injections, etc., but it is kind of a few and far between. The ombudsman technically can't step in and say, nope, sorry, you gotta, because that is still that RN's license, and they do still have the right to say, no, I'm sorry, I'm just not comfortable with this individual. Because and if it's scheduled, that's a whole different thing. Scheduled insulin doesn't tend to be as big of an issue, but sliding scale does, because that, if most of you probably know the difference. Sliding scale, the blood sugars have to be tested and the insulin has to be met out based off of where their blood sugar level is. And that's more of a difficult call to make. If it's just like, yeah, we give them, blah, blah milligrams of insulin once a week or once a day or twice a week or whatever, that tends to be a little bit easier for them to manage. And I'm sorry, you do.
And we have an RN, Lavina.
Oh, I was like, I could see you got your hand up. So yes, please jump on.
Yeah, I was just going to say there's actually a rule about delegations, and the to be able to delegate, the patient or member has to be either stable or predictable. And so if you can't meet that and you do it anyway, your license is in jeopardy.
Well, you got the resident expert then giving you the actual answer. So I don't think I was fully off. I think that is the answer that I get all the time when I do talk with RNs that are just not either willing or able, apparently. It sounds even more like it's an able issue, based off of the individual's insulin needs. So, but yeah, the ombudsman would not be able to step in and require that an RN delegate their authority. And
Lulhati.
Nati?
So as far as the delegation in an assisted living, I don't think I know there's a contract like RN that will go to the homes and delegate it to the home care worker, but insulin is like another issue. And then what I was going to say regarding this scenario is that a care coordination meeting needs to happen. Again, going back to the health literacy and getting the buy-in from the individual, like what is their cognitive level as far as retaining the information and really like engaging the client to say, hey, this is mostly on you and your cooperation. Your cooperation is greatly going to affect the success of us maintaining your diabetic level, your insulin level, simply because, you can't get it to work unless you have the buy-in from the individual, and their level of cognition to retain that information is a concern. And where if they're not able to retain that, then of course you have to, go to the next step. What is, safe for this individual? And this happens a lot, whether it's even just for them to take their meds and they're understanding at an assisted living what level of care is, being afforded to be provided to them, as opposed to the next level of care, which is like a nursing facility where you will have the charge nurse or the staff nurse providing that insulin for them.
Crisstina, I'm curious. As older adult behavioral health specialists, we're very familiar with assessments and doing the SLU or the slums. I call it the SLU because I hate it when it why. So
Yeah, I know that.
I know it's a horrible name. So the slums or the MOCA, how much do you work with those assessments? Do you kind of ask for those to be initiated sometimes with your clients so that you can kind of track what their progress is? Like how often is that actually something that you put forth to happen?
Currently, right now, I'm working on getting a couple of the neurocognitive tests run because I'm noticing quite a difference that's being reported by facility staff. And then I was actually there and fully noticed the difference. So we're actively working with the VA to get the MOCA and the slums run to maybe see where, like how, whatever. I advocate for it all the time. If I start seeing the neurocognitive decline, then I want those to be run. That being said, when they're on hospice care, they're usually not run. Because there's like a whole different mentality with regards to, when individuals go on hospice care. It's like, because again, it's so very, very limited. But yeah, any time that I'm seeing any kind of neurocognitive decline or concern, or it's being reported to me, then I advocate for the neurology. And I mean, I've advocated for this gentleman to, have these tests run and then also have things followed up with a neurologist, because if ultimately, knowing that if an individual is to be placed in any kind of memory care, if they do become an exit seeking risk, they have to have that dementia diagnosis or they can't be placed.
Mm-hmm.
So, it's important to have it on board, even if you don't end up placing him in that alternate memory care placement. But you've at least got it there. So when, if things decomp very quickly, you're not struggling to get into a neurologist, which is like, forget about it in this area because there are so few down in Southern Oregon. Trying to get into one can be a real challenge. So, like I say, if it comes up on my radar and I think it's important, I get them in as soon as possible, because worst case scenario, the neurologist finds nothing, and we've at least gone down that route. So,
Okay.
we've kind of covered this. We're at 10:30. Maybe move on. I wouldn't mind. This actually came up on my radar today. Who is all familiar with IBLs? I think a lot of us should be. The individual based limitations, like I say, that was kind of brought up earlier. Yeah, Matthew, I figured you probably were very familiar. It is something that goes through the case manager. And like I say, again, it's something that actually is between the facility and the case manager, but I usually have a pretty active role in it because I used to be an APD case manager. So I'm familiar with the process, and it's nice to know what they're potentially filling out an IBL paperwork for. But these are good ways to actually support, give the dignity, respect, etc. When IBL was supposed to be established many, many years ago, but due to COVID, the state still doesn't have a very active, what word am I looking for? Not stick-to-itiveness, but basically they still are not being actively done the way that they should be, and the agreements done and sent up to the state, et cetera, et cetera. And when they were initially trying to put them together, they were saying anyone that has a bed rail is going to have an IBL. Luckily, they kind of like reeled back on that, because bed rails can actually have a transfer and a safety thing. So, handrails don't have to be an IBL. But there are different things. I had a case in point. One of my clients was on hospice. Daughter was a little bit of a nightmare, sadly. And she was very, very disruptive to the facility. And it was a memory care. She was disruptive to not just the staff, but other residents, and also very, very dysregulating to mom. And so the facility basically trespassed her, which I can't do anything about. I mean, I advocated once she went on hospice to let the daughter be able to come in. And so we put an IBL in place, and you can actually do an IBL for that. Limiting contact. When I was an APD case manager, we limited contact for a daughter that would steal from dad all the time. So it was like she had from 8 to like 4 o'clock Monday through Friday that she could be there, and that was it. It was a very similar IBL with regards to the other daughter, just limiting so more staff is there and they're able to watch all those things. But I am not opposed to IBLs, because I do believe that they actually very much have their time and place and safety. So but the big ones that you don't tend to get very often are some kind of other restraint. I did receive an IBL from an adult foster home today about a belt for his electric wheelchair because he doesn't have very good posture because he's spinal cord injury, so he's a fall risk out of his wheelchair. So they actually have to do an IBL for the seat belt. And again, I'm completely fine with that because it's a safety thing. So, but anyone have any questions with regards to IBLs and the importance and kind of like what we look at, what we don't, what we're not super fans of where IBLs are concerned?
Matthew.
Oh,
So
sorry.
at least for the mental health division for foster care, an IBL is not considered legitimate until it has been authorized by QMHA. So the act of submitting does not mean that you can act on until it has been approved, and then it must be reviewed every 6 months. So I think that's something a lot of people forget, is that an IBL is not an immediate solution. It is an administrative process.
And I think mental health, you're right. The IBLs are slightly different. And I also want to say mental health does require doctor's orders for a lot of the IBLs that are put in place. Correct me if I'm wrong.
That I don't know. We've in 4 years here at Jackson County representing the CMHP and our vast network of foster homes. I think we've had 2 IBLs, and so they're rare. And in the words of Mike Oyster from OHA, they should be hard to get, was what he said.
I don't disagree with that. Like I say, more often than not, the IBLs I see are really, really not restrictive. Technically, they really are more for like a safety piece to keep the person safe, to keep them from falling. And I think regardless in any situation, an IBL that has the backing and support from their primary is actually always going to be much better received by the state when the state's navigating or deciding whether they think that IBL is prudent or not. And again, I don't feel like IBLs are thrown around like nothing. I feel like they're well thought out in every situation that I've dealt with in either APD or the guardian role so far. So I haven't seen them being overused or overabused. So
Perfect.
oh, because we get this all the time. Anybody want to read this? It's short. Angela?
Yeah, I'll do. So our person has chronic obstructive pulmonary disease, COPD. She wants to smoke. She is on oxygen. What do you do?
Oh, these are
What
always
setting is this person in? Do you know?
assisted.
Assisted?
Yeah. I mean, if they're in the home, there's really not a lot that you can do. And even if they're in a facility, okay, so if they're in a facility, they do become an imminent danger to themselves and definitely others, because if they are oxygen dependent,
Oops.
they'll know how unsafe that is.
So people are asking, how can she continue to smoke safely? How's the cognition?
So
So assessment for ability to smoke, like commitment to
right.
turning oxygen off when going out to smoke.
So a lot of it ends up being where the facility is comfortable or not, because a lot of facilities absolutely don't allow smoking no matter what. So if the facility doesn't allow smoking and we're placing an individual in that kind of setting and they are a smoker, we'll try to work with the facility if there are any alternatives. But for the most part, no. I mean, again, this creates a risk for the individual as well as others, staff, other residents, and the individual themselves. So this is one where you ultimately end up trying to place an individual that the facility is used to dealing with smokers, and especially smokers with this kind of situation. And if you cannot do that, you just have to like troubleshoot and are you willing to do this? Is there any way that like we've had individuals where we're able to get an agreement with a facility that they will take them out and allow them to smoke like a certain set amount of cigarettes without their oxygen with a facility member there. And it's like maybe twice a day or 3 times a day or whatever. So like I say, as accommodating as we can within safety, we will try to do, but it doesn't always work and we can't always find placements for individuals. So sometimes it is a situation where we're like, sorry, you can't smoke. Doesn't mean people don't. I get reports, one of my clients is in a mental health facility, smokes in a room all the time. I'm like, oh, and you just work with them and you have the conversation with the client. You're like, you do know you can't smoke in here. And, it's just consistency as much as you can. And, if it comes to the point where they end up wanting to evict her, that's where I'm going to have to step in and more of a harder line. And because then that puts her again at a different form of like imminent risk. So,
I went to the next slide to kind of,
which actually kind of was to the point of
goes
what I
with
was
that.
gonna say.
Matthew says that he has seen facilities keep lighters in the med cart locked. So this means the consumer requests and the staff are aware they're going to smoke.
So that is the same client that I just mentioned. I made an agreement with the facility that if I purchase her cigarettes and a lighter, then you hold on to them. She has to come to you to ask for a cigarette. That means you're going outside, but it wasn't ending up working out like that. There are a lot of individuals at the facility, and she would get cigarettes from other people. So it's still an issue. But yes, that's if you can get your individual to be compliant with that. Most of the facilities want to allow people to do what they want to do. They're not trying to be like, nope, sorry, we don't want you to be happy or do any of the things that you enjoy. So it's a matter of very consistent checking in and very consistent troubleshooting with facilities, oftentimes for the needs of our clients that aren't just normal. They need to be fed and they need to have their laundry done and they need their room cleaned. When it's a little bit more above and beyond it's consistent conversations with staff.
Okay. Can we get a volunteer to do number 7?
Sure, Angela.
Thank you.
Okay. Autonomy scenario, isolation. 80-year-old woman with cognitive impairment, schizoaffective disorder, and general anxiety. Rarely wants to leave her room for anything. Doesn't want to leave her room for meals. Assisted living facilities, worried about social isolation and increasing inactivity leading to loss of strength and mobility. They say they cannot deliver meals to her room. What else do you want, need to know? What standards or ethical principles need to be considered?
Does anyone have any thoughts?
Well, I have an actual person. She was deemed isolating herself. She doesn't want to leave her room for meals. And she was at one point eating in the congregate setting for her meals. And what happened was she had stopped going to get her meals there in the congregate room because they had moved her table. And she felt like she did not belong. And they didn't realize that that's what happened. So I was like, oh, what happened? What was the change? What changed for you? And then the other one was she did not like her so they finally put her table back. And she had severe depression. Her PHQ-9 was over 19 or something. I think it was 15. Anyway, mobility was an issue for her. She uses an electric wheelchair. It takes a long time for her to transfer. So one of the things that I had asked her was the health literacy piece, how her mobility and her limited social isolation also contributes to her depression and also contributes to um, like the diminishing of brain health, like not being able to converse with anybody, interact with anybody. So I helped her identify some of the options that she can do. Like, hey, if you don't want to, you're not in the mood to interact with people, just go inside the hall, just go back and forth. The other one was she has a dining table in her apartment. It was full of stuff, so she recognized that she can use the dining table instead of just eating on a recliner or doing all her activities on a recliner. We talked about behavioral activation, and she did not she didn't think that that was like a thing, just, hey, the more I'm isolated, the more I avoid, the more my depression symptoms will increase. And so slowly introducing her to some of these options, she actually goes to congregate meals once a day, and then she has her meals. If she decides to have her meal in her room, she uses her dining room area versus the recliner. We identify a weekly activity that she wants to engage in that's offered by the facility. Her first thought was that the activities are so boring. And I said, well, maybe the secondary benefit is that you meet up with somebody and actually talk to somebody else as opposed to just going to the activity. And so she didn't think about that. And then just going shopping, I said that is part of, decreasing your symptoms of depression. And the health literacy piece was her understanding how all that or lack of her engagement was actually affecting her physically.
It's good. You addressed a lot of things, the most important things that you need to. And that's perfect because you got her thinking, which is oftentimes, again, when we know our clients are not making the best decisions, you have that round spherical conversation like, okay, well, so these are all the things, da da da. That being said, from a fundamental perspective, if they're Medicaid, especially, the facility is required to bring their meals to their room. And the facility can't really say much of anything about them self-isolating. That is actually their choice. I mean, again, does it become a concern and would it be, conversations that I would have with my people? Absolutely. But ultimately, it is their right. Sometimes you get a little bit older and you're just not comfortable or you haven't really felt that, that connection or whatever. And it's completely acceptable to isolate. But like I say, you took a very good, well-rounded approach to hear all the things, and it sounds like she was receptive. So that's awesome.
Kathy made a good comment on finding out if this is a change in behavior or is this a baseline prior to living in this setting.
Right.
So yeah, doing that due diligence of finding out. Matthew, is this a UTI? That should be we should have like t-shirts and hats that say that. Is this a UTI?
Oh, yeah. Yeah.
The very first thing.
I will find it forever fascinating how often I have to fight with hospitals to get them to test someone for a UTI. And I'm like, really? You're the healthcare professional. You should know this. This should just be like get a clean sweep, test them for it. Almost like when there's any kind of like altered mental states, all that stuff. It's just like, yeah, I'm shocked at how difficult that can be sometimes, I have to admit.
I have to also admit pretty much every negative behavior that was not baseline and stereotypically geriatric women, and it can happen with the men, but stereotypically the geriatric women is a UTI. And generally, until people pick up on the signs and symptoms, it then becomes to the point you have to send them out as opposed to catching it early. But I am right with you. I mean, even in mental health homes, I start seeing incident reports. I'll raise the question, have they been tested for UTI? And so, yeah.
I didn't really think about that. You're like, really?
Yes.
But whatever, maybe let's think about it now. So yeah, it's kind of funny. I think we have about let's go to 9.
Okay. Yeah.
This is a good topic, and there's a couple slides that go through because it's part 1, part 2. So sexual expression, this tends to be something that's underrepresented, underspoke about, all of that. A lot of people aren't comfortable having these conversations, but there's a whole ethics and sexual, sexuality and independence with regards to sexuality under guardianship. So, and this was actually my client when I was an APD case manager. So I was already familiar with him. But it's another deputy's client because this was when I was still in APD. So 83-year-old male with dementia lives in secure memory care facility, has developed a sexual relationship with another resident. What do you need to know? What standards, ethical principles need to be considered?
Consent, I think, is the first one.
We dealt with that at the memory care facility, and what we had to do as staff is just monitor for safety, but we could not just open the domicile for, just because. And generally, the wife would come and visit the husband, and then on the graveyard shift, us graveyard staff would recognize that other women would go in with him. We couldn't ethically tell the wife, and then we also had to question that if what do we do about the prospect of STIs, but that's that person's right to have, and not their right to be outed. But it really just became, do we tell the wife that's visiting and create a problem there, or do we just ensure that when two consumers who appear to consent by virtue of not being coerced to go into each other's room, that they're safe?
It shockingly happens a lot in both RCFs and ALFs. I did not realize that it was so prolific until I became an APD case manager. I was like, well, I mean, I'm glad to know that they continue on with, that proclivity to want to do that. So, I mean, it's good, but yes, it's a matter of, is consent there? Are they being as safe as, possible? As long as there isn't coercion is kind of a place where you can step in. And this gentleman was not it was a little bit abusive towards his girlfriend. Ultimately, by the way, the memory care allowed the girlfriend and him to move into the same room. Because he was terrible. He did not like other, men sharing the room, but he was actually okay with her sharing the room. So they kind of like killed two birds with one stone, for lack of a better way of putting it. But yeah, it's really, we're not able to put a kibosh on it. That same facility, I had a wife that would go in and bring her husband, who did not remember her at all, bring him and whatever girlfriend of the day or the week or the, month or whatever. She'd bring him gifts. She'd sit there and, interact with him. She just knew. She knew he didn't remember her. It was not intended to be hurtful. And, she just wanted him to be happy and safe and would just enjoy the visit with him and whatever girlfriend he had at the time. It's way more common than most people think. So POA for the other resident initially supported the sexual relationship. Staff started noting aggressive and jealous behaviors between the two individuals, and then behaviors were reported to DOPG and POA. At that point, you start questioning and you really have to start paying attention. So, at that point, we were getting a lot more reports from the facility and making sure that this remained a safe thing. They did remain living together in the same room until she actually passed away it's like 2 years ago, a little over 2 years ago. And yeah, but I mean, ultimately it was allowed to continue, even with the aggressive and jealous behaviors that the gentleman had. And he was very, very delusional, delusions of grandeur, like schizophrenia. He owned all the Coca-Colas in the world, owned all the McDonald's in the world. I mean, yeah, he was a very interesting individual. So
In the chat, we have some questions that we went over, a few of the things on consent. What is the facility's policy on sexual health among residents? Is this something that we see in communities, that there are
one of the largest STI and STD populations currently is individuals over 65.
Yeah. I think that STI, yeah, STI seems to be the main focus when it comes to, for me, the discussion around sexual health in older adults. We are always looking at STIs and not necessarily like the other aspects. So, yeah.
But all things are definitely discussed, and obviously, they can test for them. And it's not that more often that memory care, they maybe aren't as self-aware if they did get one, but in assisted living, I mean, they're aware when something is happening with them where their their health in that aspect is not good, so they're able to self-report. The facility staff just have to keep more of a finger on it in memory care situations because they're not as self-aware. But yes, they have every right to sexual expression. They do try to monitor it more closely for all the things that we've already discussed. But they technically can't deny them unless, again, that imminent danger piece comes into play. If someone becomes abusive, or it's not being consented to, then staff can step in. And then they would obviously ask the POA or the deputy guardian to step in, and you would just kind of go from there and troubleshoot.
Perfect. So we have 9 minutes left. So if we can open this up for any questions, or if you have your own case that you want to kind of bring forward that you've had some difficulties with in the past, I think that would be yeah. So if anyone, I can go first, just to
Please.
something that one of our case managers brought to me in a care consultation was that they were confused or disappointed, maybe, that one of their clients that was in a mental health residential home needed a pacemaker, and they refused to get a pacemaker. And this is something that they were really not understanding why the guardian couldn't make that happen, knowing that if they did not get that pacemaker, then their likelihood of them surviving was very little. So what do you say about that?
So, okay, so the guardian was not going to step in. So what the guardian would have done, or at least what I would have
Well,
done.
actually, they did not have guardianship. That's
Oh.
right. They were hoping that emergency guardianship could be granted so that this person would, get the procedure. But as we connected with the guardians, that's when they said, that's not in our role. So,
And I mean, technically, it's not. An individual does have a right to make poor decisions. And you wouldn't really get like an emergency guardianship. The courts wouldn't deem that as being a valid reason to get like an emergency guardianship, because it's like they're making that choice. They don't want the pacemaker. Do they know the ramifications of what they're choosing? Oftentimes, more often, yes. And if a referral was put in and that guardian, or the potential guardian that's doing the assessment, is talking with the individual, and they can fully ascertain that this individual knows the decision they're making and are choosing to make it anyway, there wouldn't be anything that a guardian would even do. So
I had a situation like that in foster care. The consumer came in. I met with the guardian on the day of intake. The consumer had a previous advance directive, and the guardian was trying to say that the advance directive then was no longer valid because the guardian is the one making those decisions, but yet that advance directive had predated them having guardianship. And it took myself explaining to the guardian that this person's right to consent and had made decisions pre-guardianship are still in effect.
Yep.
But that guardian really honestly believed that they had power to override a previously dictated advance directive.
So the thing that's always taken into consideration again as well, if they had any prior standing, anything like that. What we always try to assess as guardians is when they were able to make these decisions, what would their choice have been? We're not trying to supersede or override that, moving on into the future at all. And if you need a little bit more backup, you can even reach out to any natural supports or family members or whatever. But that advance directive speaks volumes. That's where they were. That's what they wanted when they were in their right mind. And we respect that as guardians. That is our role. So yeah, that would have been
So,
an inappropriate decision in my guardian ethics. And yeah.
That would have nearly brought an ombudsman in if it had not been resolved in that very moment.
Could have, absolutely. Yep.
so we have some questions in the chat. So Matthew put, is there a difference between public guardian and family otherwise? And then Karen, piggybacking on Matthew's question, when can someone get a public guardian versus a guardian like with their local agency, Central Oregon Guardianship Assistance Program?
A guardian is a guardian is a guardian. There are very limited Oregon Public Guardian and Conservatives. I think I've one of 14. There are a few small pocket agencies around the state that have public guardians still. And really, there isn't a difference between a private and a public. The court's always a big fan of if you can have a family or a friend, family member or a friend. We always ask that when we're going through an assessment, we will talk with all family members and say, hey, would you like to take on this role? Because the courts would prefer that because they're that much more intimately familiar with what that person's needs and wants have been their entire life. A lot of times it's too overwhelming, or they've been dealing with that situation, whether it be mental health, substance use, whatever, for so long that they just don't have the capacity or the bandwidth to be able to take on guardianship. So there really isn't a difference. The process is the same. The petition is the same. The annual guardian reports. Interestingly enough, who you petition through with the courts, the attorney or whatever, they actually submit the annual guardian reports for persons, individuals, and oftentimes quote unquote private guardians. Whereas public guardians, we're actually the ones that put that annual guardian report together and submit it to the court once a year. So it's very, very tiny differences between the two. Essentially, the role is the same. Potentially the way that we structure things might be a little bit different, but yeah, I mean, not a whole lot of difference.
Perfect. So we just have 2 minutes left. So I would love to give anyone last minute chance to put in a question or a scenario in the chat. If we don't get to it, we can email you. So we will be sending out a follow-up email with the slides, a link to the recording of this, and then also I'll work with Crisstina in getting the most up-to-date intake packet from
Absolutely.
OPGC. We'll send you that out, and
Share my email and my
yeah.
contact information with them as well. I'm happy to answer questions above and beyond the presentation.
I know
Yes,
this is not a quick question, but is it reasonable that guardians are available 24/7, after hours, holidays, etc.?
We have a guardian on call 24/7, 365. We all take 7-day on-call shifts. And yes, it's a 24/7, 365 job. So we just all manage it together. Like I say, I just kind of got off about a week and a half ago, a 7-day stretch, and we all take 7-day stretches all year long, holidays. Yeah. So
okay. And Luhati.
One last question. Is there a cap on how many cases? What's the caseload per guardian?
it really kind of depends on the situation. Guardian, my boss, Chris Rosen, he likes to keep us below 22. because we do a lot more overreach than a lot of like private guardians do. And so like 22 is there are private guardians that have larger caseloads. Potentially that's a little bit more financially driven. And like I say, they're doing lesser interaction, hands-on interaction with their individuals. So they're able to take on a little bit of a bigger caseload. And Chris also wants us to be able to give the quality time to our people. He doesn't want to overwhelm us. He doesn't want to, in any way short the clients. He wants us to be able to give good quality time to our people. So,
awesome. Well,
so yeah,
thank you so
about 20.
much. 22. That's lower than other case managers.
Yes.
Yes. So thank you so much, Crisstina, for an interactive and informative presentation.
Thanks very
And
much for having me. It was great.
yeah.
Glad
So
everybody
our
interacted.
next GeroComp series is possibly not until July. We might slide one in for June. We will see. But the next one is by Nirmala Dar, who's going to be talking about anxiety with older adult clients. So thanks, everyone. Have a good day.
Thank you. Bye-bye.
Yeah.
Angela.
Yeah, let me stop the recording really quick.